regimen to include a booster dose will require the approval of a supplemental BLA. And the supplement must include data that demonstrate that the additional dose is safe and effective. There is an expectation that demonstration of effectiveness of the additional dose is based on adequate and well-controlled clinical trials. However, findings of effectiveness of the additional dose, while necessary, is not sufficient for an FDA approval. A determination that the additional dose is safe for the intended use is also required. Next slide, please. The evaluation whether the additional dose is safe involves weighing whether its benefits outweigh its risk. That means that available data should support the effectiveness of a booster dose, specifically against currently circulating SARS-CoV-2 variants, and the benefit of the booster dose should be considered relative to the benefit already provided by previous vaccinations with the primary series. Considering risk, available data should at a minimum characterize the most common adverse reactions that are associated with the booster dose. And uncertainties regarding benefits and risks are also considered. Next slide, please. Post-authorization data demonstrate an increased risk of myocarditis and pericarditis, particularly within 7 days following the second dose of Comirnaty. The observed risk is higher among males under 40 years of age than among females and older males. The observed risk is highest in males 16 to 17 years of age. It is not known whether there will be an increased risk of myocarditis, pericarditis, or other adverse reactions after a booster dose of Comirnaty. Thus, risk-benefit considerations to determine whether to approve a booster dose will need to be informed by the known and the potential risks of the vaccine. Next slide. So to summarize, benefit-risk evaluations should take into account whether the booster dose will prevent severe cases of COVID-19, including those caused by currently circulating variants, in addition to those prevented by the primary series. The safety profile of the additional dose will also be considered. FDA's evaluation, supported by VRBPAC, of the safety and effectiveness data of a booster dose of Comirnaty in the age groups for which it is currently licensed is thus essential. And this concludes my introductory remarks, and I look forward to a robust and transparent and evidence-based discussion. Thank you. I turn it back to you, Dr. Montu.
Thank you so much, Dr. Gruber, and I want, as an individual and representing the biomedical community, to thank you for your years of service. They really are appreciated and have been extremely valuable. Next, I'd like to turn over for further background to Dr. Ramachandra Naik from OVRR. Dr. Naik.
Thank you. Good morning, everyone. My name is Ramachandra Naik from the Division of Vaccines and Related Products Applications in the Office of Vaccines, and I am the Review Committee Chair for this supplemental BLA. I'm going to provide background for today's Advisory Committee meeting regarding Pfizer-BioNTech supplement to the BLA for the mRNA COVID-19 vaccine Comirnaty for a booster dose in individuals 16 years of age and older. This is the outline of this background talk. This provides brief description of the licensed vaccine, that is Comirnaty, overview of Comirnaty supplemental BLA and the clinical package, and overview of today's agenda, and finally voting question to the committee. Comirnaty was licensed on August 23rd, 2021. This is the only approved COVID-19 vaccine in the U.S. The vaccine is indicated for prevention of COVID-19 caused by SARS-CoV-2 in individuals 16 years of age and older. Comirnaty is administered intramuscularly as a primary series of 2 doses 3 weeks apart. Each 0.3 ml dose of Comirnaty contains 30 micrograms of a nucleoside-modified messenger RNA encoding the viral spike glycoprotein of SARS-CoV-2. Topic for today's advisory committee meeting, the booster dose supplement to the BLA for Comirnaty. The supplemental BLA was submitted on August 25, 2021. A single 0.3 ml dose of Comirnaty containing 30 micrograms mRNA is supposed to be administered approximately 6 months after the second dose in individuals 16 years of age and older. The clinical package includes safety and immunogenicity data from approximately 330 participants who were re-enrolled to receive a booster dose of Comirnaty approximately 6 months after completing the primary series of 2 doses. Breakdown of these subjects and details of the data will be provided in later presentations by Pfizer and the FDA. This is the overview of today's agenda. After this introduction and background, CDC's Dr. Sarah Oliver is going to present the epidemiology of pandemic CDC Delta variants and breakthrough infections, followed by Dr. Jonathan Stern's presentation. He's a professor at University of Bristol. He's going to present data on real-world effectiveness of COVID-19 vaccines. Later, Dr. Sharon Elroy Prius. Oh, don't see the slide. Dr. Sharon, I'm sorry. So Sharon Elroy Prius, Director of Public Health Services, Ministry of Health Israel, and Dr. Ron Milo, Professor at Weizmann Institute Israel. They're going to present the data from Israel, booster protection against confirmed infections and severe disease, followed by a 5 minutes break. After the break, Ms. Donna Boyce and Dr. Bill Gruber will provide the applicant presentation, followed by FDA presentation by Dr. Juhi Lee, who is going to present the clinical data submitted to FDA by Pfizer. After that, there will be a lunch break. After lunch, there will be open public hearing and followed by a short break. There will be question and answer session regarding the applicant and FDA presentations, followed by committee discussion and voting before adjournment of the meeting. This is the question to the committee. Do the safety and effectiveness data from the clinical trial C4591001 support approval of a Comirnaty booster dose administered at least 6 months after completion of the primary dose for use in individuals 16 years of age and older? Please vote yes or no. Thank you. That's the end of the background.
Thank you, Dr. Naik. Next, I'd like to turn over to Dr. Sarah Oliver of the Division of Viral Diseases, CDC, who will update us on the epidemiology of pandemic CDC Delta variant breakthrough infections. I assume that CDC identified, not at the CDC. I'd like to make sure that the speakers from now on will stick to time. We are going to have some real problems if we go over, because we have a very important discussion at the end of the day, and that's why I skipped the questions that are on the agenda for Dr. Naik. We'll get to some of those later on. I believe we need very much to keep our focus on the next talks. Dr. Oliver, please.
you so much, and good morning. So today I'll look at COVID-19 cases and hospitalizations, COVID vaccines administered, and COVID vaccine effectiveness. We'll look at estimates for VE over time, VE during times of the Delta variant, and VE for older adults. So first, for COVID cases and hospitalizations. To date, over 41 million cases have been reported in the US. This slide shows the trends in the number of COVID cases reported daily, with the 7-day moving average in red. As everyone is aware, we're currently experiencing a surge in cases, second only to the surge seen in the winter. The current 7-day moving average is around 145,000 cases per day. This slide represents the daily trends in the number of COVID-19 deaths per day in the US. The 7-day moving average is 1,300 deaths per day. So then this slide shows the weekly trends in the COVID-19 associated hospitalization rates in the US by age group. Rates have been increasing with this recent surge, but are somewhat less than what was noted this past winter. However, as we consider these rates, it's important to see hospitalization rates among the vaccinated compared to the unvaccinated population. The figure on the left shows hospitalization rates among 18 to 49-year-olds. The middle is 50 to 64-year-olds, and the bottom is 65 and over. Note for each of the graphics, the scale on the x-axis is different. The green line at the bottom of each figure is the hospitalization rate among the fully vaccinated individuals. And the blue line is the hospitalization rate among those unvaccinated. Among adults 65 and over, the incidence was 13 times higher in unvaccinated. And for those less than 65, the hospitalization rates were 22 to 23 times higher in unvaccinated individuals. This slide shows the variance proportions among the sequenced lineages. The blue color on this figure represents the alpha variant, and the orange color represents the delta variant. You can see for recent weeks, delta represents around 99% of sequenced lineages. As booster doses of COVID vaccines would only apply to those who had already received a primary series, I can highlight COVID vaccines already administered. So to date, there have been over 380 million vaccine doses administered in the US. The left shows the number of people fully vaccinated by vaccine series type. And on the right is the percent of fully vaccinated population by age. 63% of those 12 and over, 65% of those 18 and over, and over 82% of those 65 and over are fully vaccinated. So this figure shows the daily trends in doses administered over time. We hit a peak of around 3 to 4 million doses delivered per day in the spring, with a decline into the summer. However, the average number of doses administered has increased since mid-July. This slide shows the proportion of the population receiving at least one dose. Among older adults in purple, those 65 and over at the top, 90% or more have received at least one dose. And among younger adults and adolescents in yellow, around 50 to 60% have received at least one dose. So now to move to COVID VE estimates. First, we'll look at data available over time. I want to highlight some recent publications that we're pulling data from, listed here. This slide shows the VE estimates against hospitalization from studies listed on the previous slide. You can see VE estimates have remained high over time. This slide shows VE estimates against infection over time. We've seen some decreases in VE estimates for the last 1 to 2 months. There are a variety of reasons where we could be noting this decline. One aspect could be waning of immunity due to time since primary series. However, there is another factor to consider as well. As we've described previously, since earlier this year, we've noted increases of the Delta variant. In late May, Delta was around 7% of sequenced isolates, and by mid-July, this was up to 94% of sequenced isolates. The impact of the Delta variant leads us to this next aspect. What is VE with the Delta variant? So this slide shows results of studies that compare pre-Delta versus Delta estimates for VE. Infection or symptomatic disease is on the left, and hospitalization or severe disease is on the right. In studies comparing pre-Delta and Delta time points, pre-Delta VE estimates are high. VE against infection ranged from 72 to 97%, and against hospitalization from 84 to 97%. Since the introduction of the Delta variant, VE against infection has ranged from 39 to 84%, and VE against hospitalization has remained high from 75 to 95%. This figure shows the VE estimates by outcome for the Alpha variant in blue compared to the Delta variant in orange. The outcomes range along the top, VE for any infection on the left, symptomatic infection in the middle, and hospitalization or severe disease on the right. You can see that among global studies assessing infections with Alpha versus Delta, there was a mild decrease in Delta VE. This may be due to a variety of factors that can impact these results and variation by country, including differences in study methods, different intervals between doses, and timing with vaccination and the variant increases. This is a summary of VE estimates since the introduction of the Delta variant. The colors correspond to the vaccines assessed in the study. This highlights that regardless of the vaccines evaluated, all vaccines have remained effective in preventing hospitalization and severe disease, but may be less effective in preventing infection or mild illness recently. The reasons for this lower effectiveness likely include both waning over time and the Delta variant. So next, to address VE for older adults. This slide shows unpublished COVID-19 data with VE against COVID-19 associated hospitalization among fully vaccinated patients 18 years of age and over by age group and month. COVID-19 conducts hospitalization surveillance with 14 states, representing around 10% of the U.S. population. Patients must be a resident of the surveillance area and have a positive SARS-CoV-2 test within 14 days prior to or during the hospitalization. Chart reviews are conducted. Data presented at last month's ACIP meeting showed a lower VE in those 75 years and over. However, we're constantly getting updates to the data with backfill for previous months. With these updates, the COVID-19 data through July now show that the VE against hospitalization in adults 75 and over remains over 88%, while the VE for this oldest age group has consistently been slightly lower than the other age group, it has remained quite high and generally stable for the last several months. So then this slide shows data from the VISION platform evaluating VE against hospitalization, as well as urgent care or ED visits. VE against both outcomes was consistent, at least 82% or higher, through at least 16 weeks after the second dose. Note this data is through June of 2021 and may not represent a full picture with VE with the Delta variant. This study highlights VE for symptomatic infection with the Pfizer vaccine for several of the recent variants of concern. Adults 60 years of age and over are in the light blue. VE against symptomatic infection in adults 60 and over is high, but some decreases are noted against variants of concern. However, it's important to note that these differences were not significantly different. There were small numbers and very wide confidence intervals for several of these variants. These figures show VE by age and time since vaccination. Infection is on the left and severe disease is on the right. Adults 60 and over are in light blue. Effectiveness against infection was over 60% in the first 5 to 9 weeks after vaccination, with a gradual decline. Protection against severe disease has remained stable, with a decline noted in those 60 and over after 25 weeks. However, also notes the very wide confidence intervals for these later estimates. This slide highlights VE against hospitalization by time since vaccination in adults 65 years of age and over. VE has decreased slightly over time, but remained high. And again, differences by time interval since vaccination were not significantly different. So next we can consider long-term care facility residents. There was some question initially for how these older, potentially medically frail adults may respond to the vaccine at all. However, this shows that initially, VE against infection was 74% or higher by vaccine. However, as we look over time, moving into the recent months where Delta was the primary variant, VE against infection has fallen to just over 50%. So then this is the same summary slide as before, but the other ages are grayed out, and we've added the estimates for adults 60 years of age and over to put these estimates for older adults into the overall context. Lower VE against infection was seen for older adults, particularly the long-term care facility residents. Follow-up is needed to monitor these VE results over time. So in summary, COVID vaccines continue to maintain high protection against severe disease, hospitalization, and death. Protection against infection, which includes asymptomatic or mild infections, are lower in recent months. However, it's difficult to distinguish the effects of increased time since primary series versus the impact of the Delta variant. And it's important to monitor trends of effectiveness by severity of disease over time. I want to thank the team of people that have helped pull this together, our ACIP team and the entire vaccine effectiveness team at CDC. I'll highlight that the next two slides contain references that were listed, and I'm happy to take questions. Thanks.
Thank you so much, Dr. Oliver, and thank you for keeping us to time. We do have time for a few questions before we move on to the next presentation. Dr. Gans.
Thank you, Dr. Oliver. That was very helpful. I'm wondering if you could elaborate a little bit more, because they seem to be lumped by Pfizer, Moderna, and the breakthrough disease. Can you elaborate more in just the since we're thinking about Pfizer at the moment application? you give us more information about breakthrough disease and how it relates just to the Pfizer vaccine? Were the large majority of those Pfizer versus Moderna?
So some of that has to do with the study platform. Several of them don't have the power to split apart individual vaccines and still get stable estimates. So many of them had to lump kind of mRNA vaccines together. There were some, and a few of the slides did look at kind of if you compared if we had estimates for Pfizer and Moderna that are in there, but many of the platforms had to kind of lump the mRNA vaccines prior receipt together. I will say the Vision platform is one of the larger ones, and it has been able to obtain product-specific estimates, and so I can share those platforms, the estimates with you. I think compared to the Pfizer estimates were slightly lower than the Moderna estimates, but we'd have to kind of monitor that over time and look at it across various platforms.
Dr. Chatterjee.
Thank you. Dr. Oliver, thank you for your presentation. My question is with regard to mitigation measures in addition to vaccination. Obviously, these have an impact on risk of exposure, and I was curious whether any of these studies address those measures and the impact that they might have.
Yeah, it's difficult. If you kind of overlay a lot on the time, we know that sometime as Delta was taking over, there were also changes in how we were doing some of our social distancing and non-pharmaceutical interventions. I know several of the studies have attempted to look at this. Unfortunately, it's really difficult to look at to get kind of behavioral interventions and data on masks and behaviors in this. So we'll continue to attempt to measure, but I know it's been difficult for each of the platforms.
Thank you.
Dr. Kurilla. One more question after Dr. Kurilla before moving on.
Thank you, Arnold. Sarah, it's convenient to divvy up the population into vaccinated and unvaccinated, but there actually is a subgroup that is unvaccinated but prior infection, and that has been increasing over time. And failure to account for that would seem to actually underestimate vaccine efficacy going forward. So I'm wondering, have you attempted to take that into account in terms of actual calculation of vaccine efficacy?
I know that, the platforms, many of our broader, more robust platforms do a test negative design, but they're not able to do, serology screening on everybody who would be admitted. So I don't know that included into, the specific, they're not like screening for serology prior to including unvaccinated individuals. But I know that several of the platforms, Vision, Ivy, attempt to account for this with their statistical analysis.
Okay, but you haven't done any attempts at sort of bounding what that, given overall seroprevalence estimates are. You haven't done any bounding of what that may be, how that may be impacting calculations of overall vaccine efficacy?
I'll tell you, I can get back. I can check with the specific site PIs and get back to you potentially this afternoon around exactly, how their analyses have adjusted for that.
Right. Dr. Meisner, final question. You're muted.
Cody, you're Adak.
Okay. My question is the
charts and tables you showed us, some were for adults over 75, some of the data were for adults over 65, and some were for adults over 60. How do you pull that together? I mean, they're fairly discrete groups in terms of the interval of time since they received the vaccine, for example. How do you break down the risk in those different age groups?
Yeah, so, essentially what we reported is what has been published and was out there. So several of the studies we had to take, especially the ones not conducted at CDC, we had to take, the interval and age as they reported them. There is absolutely kind of a difference by age group. And so in some of the platforms where we have more people and could get stable estimates, so COVIDNet is a larger system, so we tried to break out that 65 to 74 and 75 over. Many of the platforms, though, that have smaller numbers just aren't able to get that granular. So that's why some of the platforms reported 65 and over, with an acknowledgement that there likely is, an age kind of gradient, and that a 65-year-old may not be exactly the same as an 85-year-old, but we can't necessarily report stable VE estimates for each individual age group.
Thank you. Okay, thank you, Dr. Oliver. And as I'm going to mention to all of our speakers, we may well have more general questions later on, and I hope you can stay around with us during the entire day. Next, we go outside the U.S. Our next speaker is Dr. Jonathan Stern, Professor Stern, who is at Bristol Medical School in the UK.
Thanks very much, and I'm honoured to be asked to present this important meeting, and the title of my talk is Real-World Effectiveness of COVID-19 Vaccines. These are my declarations. I don't have any financial interest with any of the firms or entities that are related to the meeting topic. And I'd like to acknowledge the authors listed here who have diligently assembled data on estimated effects of COVID-19 vaccines that I will present in the early part of my talk. So, the title of the talk is Real-World... the title of my talk is Real-World Effectiveness of Vaccines. I want to emphasize that randomized trials provide the best estimates of effectiveness of any healthcare intervention in the real world. The issue that makes life difficult in the context of the sort of question that's being addressed by the committee today is that a host of urgent questions about COVID-19 vaccines have not been addressed in randomized trials. For example, for completely clear reasons, the randomized trials were almost exclusively conducted before the era of the Delta variant. The ongoing emergency, the amazing success of the vaccines means that we have to make far-reaching policy decisions, such as the one being considered today, using observational data. But a better title for my talk might be Estimated Effectiveness of Vaccines in Observational Studies. And given that I'm going to spend my time talking about the potential biases in these studies, an even better title might be Estimated Effectiveness of Vaccines that is biased by an unknown amount, and how to think about such biases. Colleagues at the WHO and Cochrane are running an amazing systematic screening and data extraction process on published studies on vaccine effectiveness, and they are screening hundreds of studies per week, classifying them, the published observational studies classified according to whether they're peer-reviewed or are available as a preprint, and according to whether they're prospective or retrospective or cross-sectional, and according to the underpinning study design. There have been 178 such studies on vaccine effectiveness against variants of concern, as you can see here, with a number of different study designs, but primarily cohorts and test negative case control designs, and studies on, plenty of studies on the Delta variant, 76 of them. And among those 76 studies on the Delta variant that assess immunogenicity and or vaccine effectiveness, the number of studies are increasing weekly. There are 51 cohorts, 9 test negative case controls. And if we look at the outcomes considered are laboratory confirmed COVID, 57 studies, symptomatic confirmed COVID, 34, severe or hospitalized COVID, 37, and death from COVID, 16. So, and Dr. Oliver's talk last time beautifully summarized the data that's out there, particularly as it relates to the question being considered by the committee today. So those data were summarized in a paper in The Lancet published by these authors. I was a minor contributor to it. It appeared on Monday. That paper summarized efficacy overall according to variants, showing, as we've seen, that efficacy against, firstly, the efficacy against severe disease is uniformly higher than efficacy against any infection. And secondly, that efficacy against Delta seems high and similar to efficacy against Alpha. And in a small number of studies, the efficacy for early versus later follow-up appears similar for efficacy or effectiveness against severe disease, although somewhat lower for effectiveness against any infection. And this slide, diligently put together by Dr. Anna Maria Enara-Estrepo and Professor Sir Richard Pito just yesterday, summarizes the current evidences as recorded in this data set of trial of studies and study results, the efficacy of messenger RNA vaccines against severe disease in settings where the Delta variant is circulating up to this week. And as described in the previous talk, in most contexts, if you look at the middle column here, the right two columns show us the confidence interval. Efficacy remains high, and for example, the study in Minnesota, where estimated efficacy was a little lower for both the Pfizer and the Moderna vaccines, the confidence interval was rather wide in that study. I won't spend time talking about this slide. The evidence was beautifully summarized in the previous talk. So I'm going to spend most of my time talking about methodological issues in estimating vaccine efficacy during the rollout. And I'm going to give some examples from analyses that a large team of us have been doing in the UK based on the Open Safely analytics platform. We've been fortunate to establish in the UK near population coverage of detailed linked electronic health record data. And Open Safely provides a trusted research environment within which those data can be securely accessed and analyzed with appropriate disclosure controls. Now, I want to emphasize that my examples are from analyses of these data, but they're not there to tell you about the results. They're there to try to illustrate general issues in trying to estimate vaccine effectiveness from observational studies. So here are the issues that I'm going to cover, and the first and obviously important one is the problem of confounding. I'll call it baseline confounding for reasons that I hope will become clear. That's presence of characteristics of individuals that predict both vaccination and the outcome that we're interested in. So confounding occurs when there's a common cause of both vaccination and the outcome event, which might be symptomatic infection or hospitalization with COVID. And in that circumstance, the association that we estimate in our observational study may not equal the causal effect, the effectiveness of the vaccine. The reason that we randomized fundamentally is that randomization should remove confounding in a high-quality randomized trial by removing the link between prognostic factors that influence the outcome, and vaccination, because only the play of chance determines whether someone's vaccinated. Now, here's a graph of the rollout of vaccination in England from Open Safely in the over 80s in the upper panel. That started on the 8th of December 2020, and rather later in the 70 to 79-year-olds, which started in January. And here, vaccination with Oxford AstraZeneca is in green. Vaccination with Pfizer BioNTech is in purple. And you can see what's characteristic of countries that achieve rapid rollout with high take-up is that we see rapidly we get to a point where very high proportions of the population have been vaccinated. The light purple here is receipt of second dose of Pfizer BioNTech, and that happened for only some people vaccinated with Pfizer and almost nobody vaccinated with AstraZeneca, because the UK changed its vaccination schedule to 12 from 3 weeks early in January 2020. So when we look at this, we can ask, well, what predicts the speed of take-up, speed of being vaccinated? What factors predict being vaccinated faster rather than slower? And that's what's shown on the next slide here, which shows estimated hazard ratios for people aged 80 years and over in the left two columns of figures, and people aged 70 to 79 years in the right two columns of figures, separately for Pfizer, BNT162b2, or Oxford AstraZeneca, ChAdOx1. And I'll just highlight a few results. This is just to show you that patient characteristics that predict occurrence of COVID outcomes also predict whether you get vaccinated, even in a situation of rapid rollout and publicly funded healthcare such as in the UK. So even within these age groups, age influenced whether you got vaccinated, and not necessarily in the same direction or consistently for the two vaccines, because it depended on logistical issues. Even in the context of this publicly funded healthcare system, less deprived people in group 5 were vaccinated faster than more deprived people in group 1, and that was true for both vaccines and both age groups. It's well documented that vaccine hesitancy is related to ethnicity in the UK and in other countries, and sure enough, white people got vaccinated faster than people of other ethnicities. People with learning disabilities got vaccinated slower, and previous vaccination, which may be related to underlying healthcare behaviours or vaccine hesitancy. So previous people who'd received flu vaccine in the previous 5 years, that may also be related to comorbidities, were more likely to be vaccinated with the COVID-19 vaccine. So there is every reason to think that estimates of vaccine efficacy will be subject to bias due to confounding. One way to address that is to adopt a test negative design in which we don't look at the whole population. We compare individuals with symptoms who test positive, the cases, with individuals with symptoms who test negative, the controls. Now that may reduce confounding, but as has been well documented, and here's a pair of papers in the American Journal of Epidemiology published in 2016 discussing the test negative design in the context of flu vaccination. There is no reason to think that just by doing a test negative design you will remove confounding. And there are various consequences of test negative designs that are discussed in detail in those papers. So I think that in the context of COVID-19 vaccination, careful evaluation of the potential for bias in estimates of vaccine effectiveness from test negative designs seems warranted and indeed urgent. So back to my graph of the cumulative incidence over time, because it tells us the next problem we have when we try to estimate vaccine effectiveness, which is that if I take somebody who's unvaccinated on a particular date, for example, the 15th of January 2020, then that person, although they're unvaccinated and they may serve as a comparator at that moment in time, is also likely rapidly to become vaccinated. And that gives us a problem in choosing a comparison group for our estimates of vaccine effectiveness. Because there's a very rapid rollout of vaccination, unvaccinated people rapidly become vaccinated. And there's a solution to that, which seems pretty obvious, which is to split the follow-up time for each individual in our population into time unvaccinated and time post-vaccination among the large majority of people who ultimately are vaccinated. The difficulty is that that gives us a new problem that hasn't been extensively dealt with in studies of vaccine effectiveness, which is the problem of time-varying confounding. So I've discussed already how patient characteristics at the start of follow-up may be confounders because they predict both vaccination and COVID-19 outcomes. But as we move through follow-up and people get vaccinated, there may also be confounding after baseline by time-varying factors, and we call those time-varying confounders. And here are some, a difficulty here is that special methods, such as, although not exclusively, marginal structural models, are likely to be needed when there are time-varying confounders. So here are further analyses from the same data set that I showed you earlier, looking at time-varying characteristics predicting vaccination in those two age groups in England. And you can see that people who had recently tested positive for SARS-CoV-2 were hugely, at least 90%, less likely to be vaccinated. And in fact, there were almost nobody was vaccinated within a week of testing positive for SARS-CoV-2. So that, and clearly that's a confounder for being hospitalized with COVID. So there's every reason to think that time-varying confounding is also a problem here. Why is it such a difficult problem analytically? Well, because it's a confounder, because having a positive test predicts whether you get vaccinated and also predicts whether you're hospitalized with COVID. But it's also on the causal pathway from being vaccinated to being hospitalized. And that means that using standard modeling strategies may not work. So we tried to do analyses using marginal structural models to overcome this problem. And these are the results, and I'll quickly take you through them. So the colors here relate to the degree of adjustment. In green, we have basically just region adjusted, but no further adjustment. In orange, we have adjustment for baseline confounders, and in blue, we have additional adjustment for the time-varying confounders. The left-hand graph is any vaccine, and the right-hand graph is Pfizer only, and the upper set of graphs is the outcome positive test. The middle set of graphs is COVID-19 hospitalization, and the bottom set of graphs is all-cause mortality. So firstly, you can see that adjusting for the time-varying confounders makes a big difference and attenuates the apparent effects of the vaccines on all-cause mortality. And it has some effects, although less dramatic, for the other two outcomes. And you can see, and this has been seen in a number of studies, that there is completely implausible protection immediately after vaccination, even when we adjust for the time-varying confounders. And I think that's just unmeasured confounding, and I'll say a bit more about that in a moment. So the difficulty we have is that even with these detailed electronic health records and using probably the best method available and controlling for an extensive set of confounders, we get implausible levels of protection. Why implausible? Well, firstly, they weren't seen in the trials, and secondly, I think it will be broadly agreed that we don't expect huge protection against all-cause mortality or hospitalization within a week of vaccination and with a first dose only. So what we'd like to do is we'd like to hope that that bias, which I think is plausible bias, that we see very soon after vaccination goes away, and that what we see later are good estimates of vaccine effectiveness. The worry we have is that, well, if it's biased early, we don't know when that bias goes away. But I think we should be particularly concerned about short follow-up after vaccination for the reasons I've explained. We get similar results for the 70 to 79-year-olds. So I think there may be a problem with unmeasured confounding, particularly soon after vaccination. One plausible explanation is that if you show up for vaccination in the UK, there's a big sign saying, please go away if you have symptoms of COVID. So people are likely to delay their vaccination if they have symptoms, and that's not recorded anywhere in the healthcare record unless they subsequently test positive or show up for healthcare. And of course, that makes symptoms a time-varying confounder, but it's not measured. So bias is because recent symptoms predict postponement of vaccination may wane with time, but it seems particularly hard to estimate short-term effects of vaccination. Another couple of important issues. Firstly, it's vital to account for the fact the incidence of the outcomes varies so dramatically over time. Here's the incidence of hospitalization in the last 6 months in the United States, readily available on the web. And you can see that you don't want to be comparing somebody on the 31st of August with somebody on the with somebody else on the 31st of July, because things change so rapidly. So we have to deal with time since vaccination as one aspect of our analysis, but it's vital that we also deal with calendar time in our analysis, and people do that in a variety of different ways, and the ways that diversity makes the studies hard to appraise. But it will usually be important to carefully allow for both calendar time and time for since vaccination in analysis. And finally, a word about persistently unvaccinated individuals. This is the other end, because we're most interested in people who've been vaccinated for some time and in whether vaccination effectiveness is waning. And in many highly vaccinated populations, perhaps less so in the US, that means we're dealing with a highly selected set of individuals whose characteristics we need to understand. And a particular concern raised in a questionnaire before my talk is what proportion of those remained unvaccinated because of recent infection that conferred protection. So it's hard to estimate vaccine effectiveness, and we need careful and critical evaluations. Here's my final slide, and I will skip through because I'm out of time. We need to think carefully about confounding. We need to think about how our analyses need to allow for the stages of the rollout. We need to control for a wide range of potential confounders. In studies of long-term vaccination, we need to ask about what proportion of the unvaccinated were protected because of previous infection. We need critical appraisal of test-negative designs. We should be very cautious of apparent short-term benefits of vaccination because of the potential for unmanaged confounding, for instance, delay to vaccination. We need to deal with rapidly changing incidence of outcome events. And finally, ideally, there should be an analysis plan published before outcome data were available to reassure us that data weren't cherry-picked. Thank you for your attention.
Thank you so much, Professor Stern. As somebody who does test-negative designs and knows the strengths and weaknesses of that design, I think you've covered it brilliantly. My first question, because we're going to be confronted with an issue of U.S. data versus outside the U.S. data, how did you handle the fact that with the mRNA vaccine, the Pfizer BioNTech vaccine in the UK, many people did not get the second dose in exactly 3 weeks, which was the protocol in the U.S., but the dose was delayed, and therefore the immune response might be different?
So the short answer is we didn't, because the analyses I showed you just looked at first dose and didn't account in any way. There are some incredibly interesting data coming soon, I believe in press, from the ONS Community Infection Survey that will speak to exactly that issue, and that may indeed suggest the UK made a good call in extending the time between first and second doses.
Right, that's exactly what I'm referring to. Dr. Kurilla.
Thank you. I don't know why my camera's not working. You highlighted the issue. Yeah, okay, good, thank you. You highlighted the issue of seeing an effect in the immediate post-vaccination period that would not be expected due to the effect of the vaccine. But I'm wondering if there is, do you think there could be a potential for a antigen-independent vaccination enhancement in some degree of immunity, and in shorter term, that period of time that will wane very quickly, but that may actually be overestimating short-term estimates of vaccine efficacy that would then change over time?
So it's possible. I mean, the difficulty for the committee is that you're making incredibly important policy decisions very rapidly in a situation of uncertainty, and there are very good reasons those decisions have to be made. I do think that we can look to the trials for good, unconfounded suggestions of the likely short-term efficacy.
Dr. Gantz.
Thank you for elaborating, elaborating some of the things that we've all been very concerned about in a very, very organized way. I'm wondering, when you apply all of the founders and all of the considerations that you've made, what are the studies that filter out at the end that you would highlight for the committee that would actually suggest that we have good, unbiased, or at the best that we have in terms of how we should be vaccine efficacy?
So I'm not going to identify individual studies, but I would identify, I tried to, on my last slide, identify characteristics, and they would include careful control of the confounders that we know are really important, such as age of vaccination, availability of vaccination, as precisely as possible, and then if possible also other characteristics from detailed healthcare records, and extremely close matching on calendar time, so that broadly speaking, somebody who experiences an event should only be compared with somebody who is being followed up on the same day. And it's perfectly possible to do that using, setting up your survival analysis in the right way. But I'm not sure that all studies have done it. But I mean, I sympathize with you because I find it incredibly hard to look at the very diverse set of descriptions of what's been done in the individual studies and to know, well, did they do the things that I've just talked about?
Thank you so much, Professor Stern. And again, we appreciate your keeping to time because we have a very busy day. Now we move to looking at booster protection against confirmed infection and severe disease data from Israel. We're going to hear two speakers who will speak one after the other, and then we will have the question period first, and I'll introduce both right now. Sharon Alroy-Price, who is the Director of Public Health Services at the Ministry of Health in Jerusalem, Israel, and then Professor Ron Milo, who is at the Weizmann Institute in Israel. Dr. Alroy-Price, please.
Dear Chairman and honorable committee members, we were asked, the Israel Ministry of Health, we were asked by the FDA to present our data on waning and booster effect, and we are delighted to do so. It's important for us to start by emphasizing that we do not pretend to tell other authorities what to do in their setting. We're here to present the data from Israel and the decisions that we came up with in our setting, and we hope that this will help other countries or enable them, other authorities, to reach their decisions with the most advanced, latest evidence that we have in Israel. Based on the multiple logos that you see on the screen, I would like to highlight that the work presented here was done by several leading academic institutions in Israel in collaboration. Knowing that the evaluation of the booster dose would be critical to Israel and the rest of the world, the analysis was done with extreme caution by different analysts from different institutions, by different analysis methods, as Ron will describe. And I would like to thank all these institutions coming together to do this work very diligently for several months. So we are both presenting, Ron and myself, and we have no competing financial interest to disclose. I would like to say that Israel Ministry of Health and Pfizer have data sharing agreement on public health surveillance data. However, since the data that we are showing here was actually done by these academic institutions, only the final results were shared with Pfizer. So I would like to take you back in time to December 2020 in Israel. We started to see a third surge in cases, our third wave, and this was actually after having 2 waves and 2 lockdowns, and when we were at the exit from the second wave, we had really pandemic fatigue in the country, and so we saw once we started opening the economy, we didn't even were able to open everything up. As we were starting to open places, we saw an increase in cases, both confirmed cases, but also severe and critically ill. And there was a significant burden on the hospitals at that point in time. And we decided on a lockdown, but as I said, that decision was not as, the compliance of the public was not as it was in the previous 2 waves. Thankfully, we had the ability to start a vaccination campaign in December. So Israel started vaccinating as soon as there was FDA approval for the Pfizer-BioNTech vaccine. And there was a quick compliance and uptake of the vaccine. We opened it in steps based on ages. And we reached a very high level of vaccine. And with that, the vaccine uptake, we started to see a decrease in cases, over 100-fold decrease in cases following the vaccination campaign. And as I said, there was a partially effective lockdown at the time. And the main thing was that when we opened the lockdown, we were able to open everything up, lift all restrictions step by step, and the cases did not go up again. We saw, and also the fact that we had reached high level of population-wide immunity early on, which was wonderful, but we also can see that we're basically 3 months ahead from other countries when we're talking about now waning. So the very efficient vaccination campaign made Israel the leading country, but when we compare it to other countries, there is a time gap. So Israel reached about 40% of the population covered, roughly 3 months ahead of other countries that have 5 million citizens or more. And that is important when we move ahead to explain why our data may be different than other settings. Before we move ahead, it's worth noting several things about Israel. First, all the residents are covered by 4 HMOs with comprehensive electronic medical record. The second point is that we have a large PCR testing capability in Israel, so we are basing all our data on PCR and not really rapid antigen testing. And 2 things that are allowing us to really monitor the effects of policy changes is that every COVID-19 test result, positive or negative, is reported online to the Ministry of Health. So we know every day how many people are tested positive and negative. And all vaccines given in Israel are reported online to the Ministry of Health. So our capability of doing really online vaccine effectiveness is comprehensive. So our third wave was mainly alpha variant, as you see, and we started seeing, or we started sequencing Delta variant sometime at the end of March, but it was really rare. It was among people traveling abroad, and it was one at a time. But there was steep increase in Delta isolation, reaching over 98% of the cases seen in June. And at the same time, we started to see our fourth wave. We are now still in our fourth wave, experiencing the highest level of infection that we have seen so far in this pandemic. And this is despite widespread over 60% of doubly vaccinated individuals, and in the vulnerable population, over 85% they are doubly vaccinated. And once we saw that, we were trying to figure out what that tells us. We saw daily cases rose by more than tenfold in a month and a half. So from roughly 12 cases a day to about 1,000 in a month and a half. And what was more worrisome is that we saw severe active cases increase by more than tenfold in a month, and among them was 60% vaccinated individuals, fully vaccinated individuals. So at that point, we had to stop and ask the question exactly as the CDC officer said, is that a Delta issue or is that a waning immunity issue? We had some clue that it might not be the Delta variant, at least not alone with its effect, because we started vaccinating 12 to 15 years old with FDA approval, and they actually had a fresh vaccine, and amongst them we saw vaccine effectiveness of around 90%. So the majority of them were protective, but still you can't really say because of the age difference and everything. So the other question we needed to figure out was what about the waning, and does that play a role? And as Ron will describe now the analysis we did, we think this is a major part of our picture in Israel at least.
Okay, so good morning everyone. What I'll be showing you are the results of the observational analysis that we did in Israel, which is after a relatively short time since the vaccination campaign. In spite of the potential biases that we described in the two papers that regarding the analysis, as well as the relatively short follow-up time, we thought it was our responsibility to analyze the data as thoroughly as we could and share it with the world through peer review. And this is what I'll be presenting today. So this is a bit of a heavy slide or complicated slide. It would be great if I also get a cursor at the bottom. But I would say let's try and follow in the following way. Let's start from the x-axis. You can see 3 cohorts, and we'll be focusing initially on the cohort on the right, ages 60 and above. On the y-axis, you'll see the confirmed infection rate per 1,000. We'll be talking about rates of SARS-CoV-2 confirmed infections. This is both symptomatic and asymptomatic based on PCR results. And I'll be talking here about people that were confirmed in the month of July. So as Sharon was saying, this is vastly dominated by the Delta variant. And the different shades that you see here refer to what happened for people that were vaccinated at different times. Starting from the dark colors would be January, meaning the ones that vaccinated early in the campaign. Okay, great. I got a cursor. Good. So you can see here, this is in the beginning. And then you can see we're proceeding here based on the month of vaccination from 6 months prior to the study period up to 2 or 3 months from the study period. And I think you can see that there is a change in the rate of confirmed infections per 1,000 people. And this is seen both at the age of 60 and above, which is what you see here, some monotonic change. And you can also view what happens with the other age groups. At the other age groups I do want to mention, you see the ones that vaccinated earliest tend to be healthcare workers or people at risk, mostly severely immunodeficient people, and therefore this should be interpreted with caution. But you can see a signal of waning both at both other cohorts that we interpret as the waning effect. You can also see here what happens in terms of waning immunity in relation to severe disease in the ages 60 and above. The y-axis is again regarding rates per 1,000 individuals in the study period in the month of July. All of those, or 99 or whatever percent, are the Delta variant, because this is what by far the most dominant. You can see that the confidence intervals, these are 95% confidence intervals, you can see that they are larger now. This is because the number of cases is smaller. I would mention that we have here over 1 million people that are being analyzed, so I would say it's not easy to get very small confidence intervals for these studies, even though the study group is very, very large. And you can see the change in rate through time. All of this, by the way, is publicly available. We made it available on the archive, and it's in the final stages of being published. Here we were asked to also present what happens in the younger age groups. This is mostly preliminary data. And you can see the ages 50 to 59, 40 to 49, and the younger age groups. The numbers are much smaller because the rate of severe disease is smaller. And therefore, the statistical confidence is also not as strong. And one could see the general potential trend, but it is hard to conclusively interpret it given the relatively small numbers. We do see what could be indications of a trend, but it depends heavily on how you want to also interpret what happens with the medical healthcare workers that were vaccinated in the month of January. There is an important point here that I want to mention that was an issue in Israel in trying to think about this. We saw in the CDC presentation and the following presentations, they were mentioning the issue of high degree of protection that you get from the vaccine for severe cases. And I want to just take a minute to show something that I found that was confusing in some of the discussions for us. There's no doubt that the vaccine gives good protection, meaning much better than not having the vaccine, and this has been shown in many different ways, and we observe it as well. At the same time, you could have high protection of, say, 97%, or you could have high protection of 85%. So 97% is what has been published, what is observed for against severe disease. 85% was mentioned in some of the previous slides and also concurs with what we seem to be seeing right now of the Delta for those that were vaccinated relatively early, meaning half a year ago. And while 85% might still seem very high, and this is only a 12 percentage point difference, I just want to point out that this translates the 97% vaccine efficacy is means 3% relative risk, whereas 85% vaccine efficacy is 15% relative risk, meaning a 5-fold increase in relative risk, which is a very large increase, a fold change in the number of severe cases vaccinated, doubly vaccinated severe cases that have to be taken care of in the Israeli hospital system. And this is in line with the values that Sharon was mentioning of what we saw, the sharp increase, over half of it in vaccinated people. So based on the evidence of waning in Israel and the trajectory exceeding national hospitalization capacity given the rapid rise in severe cases, Israel decided to begin a third vaccination campaign on July 30th, starting with the elderly. And I want to show you what we found regarding the effect of those boosts. So here is just the outline of the temporal campaign. So as I said, we started at the end of July, beginning of August, and there's been about 1 million doses given for the ages 60 and above. And you can see also the other cohorts starting with the 50 plus 2 weeks later, and then 40 plus, etc. Altogether, we're close to 3 million booster doses that were given to date. You can see it here as a fraction of the eligible population in each cohort. The eligible are the ones that got 2 vaccines. They were eligible to take the 3rd vaccine, assuming it was over 5 months in our case. And you can see that a significant fraction of the population took it, and you can see that it started mostly with the elderly, And that made us do the analysis for that age cohort, which is where we have the most follow-up time. You can also see here the fractions of those eligible that were vaccinated with the third dose to date. Overall, we're talking in the age of 60 plus that were included in the study. We're talking about 1 million people altogether, in which there were about 13,000 confirmed infections in the study period in August. We are still in the midst of a wave, and therefore there's a lot of cases. Okay, just before I get to the results, let me show you what we might be expecting, or the form of the results I'll be showing you. On the x-axis, I'll show you the days for vaccination, and on the y-axis, I'll show you the fold reduction in risk compared to 2 doses. So throughout the study, for many reasons, for example, that were mentioned in the previous presentation, we're sure to compare between those that already took 2 doses and those who decided to also take the third dose, and compare between those 2 groups and not the unvaccinated, which might contain some potential confounders. In the beginning, also as was mentioned before, there could be also some possible transient biases. In the days just following the third dose, people usually, and we see the signal, there's a tendency to go and do less PCR tests for COVID-19. But then we see that decreasing, and then we're looking at the time period of about 12 days onward, which is the time scale in which we're expecting to see the effect because of 2 reasons. One is because we know that there is time until the neutralizing antibodies response increases. That's usually on the order of a few days or a week. And then there's also a time between whenever you're infected or get protection from infection and the time this is observed through a test in PCR. That's on the average in Israel about 5 days, strongly related to the incubation period for developing symptoms, or just in general, also when you look at contact tracing, etc., that's roughly 7 days plus 5 days, so 12 days is roughly where you're expecting to see the effect being observed. So here are the results. Again, this is on the x-axis, you can see the time post-infection, and on the y-axis, you can see, and on the y-axis, you see the fold reduction in the rate, again, compared to the 2 doses. All of this has also been publicly available, and now, as we gave the slide as requested 3 days ago, but by now it's also published in the New England Journal of Medicine. All the results I'll be showing you are based on Poisson regression in order to take into account as many of the confounders as we could. It's adjusted for age, for gender, for demographic group, for the time at which the second dose was given, and the calendar date. Just as was mentioned before, that these 2 temporal effects should be taken into account. And we'll be comparing, when we're talking about protection, in the main analysis, we're comparing between what happened 12 days onward versus what happened with no booster, meaning only 2 doses. Here is a summary of the results. We're getting an estimated protection of about 11-fold. You can see that the confidence intervals here are relatively small, somewhere between 10 and 12, as a result of the many risk days that go into the analysis, and the fact that there's over 1,000 infections in this group over those 10 million risk days, and about 5,000 infections, or some 4,000 infections in the 2-dose only, no booster group. The rate difference is about 86.6 per 100,000 person days. These are the results for the age 60 and above. We also have preliminary results for the ages 50 to 59, and you can see a consistent picture where after about 12 days, we're seeing about a 10-fold protection. Similarly, for the ages 40 to 49, we're seeing, again, something like 10-fold decrease, 10-fold protection, again, doing the same kind of Poisson regression adjusted for all of those aspects. we understand the importance of doing this analysis as thoroughly as possible, and therefore we try to use different approaches. So what I showed you so far is based on the Poisson regression approach. We also use the matching approach, which is common in many of the studies for doing this. And when we're doing matching between those that got 3 doses to 2 doses, we got a very similar result in terms of the reduction in the risk. We also did another kind of analysis, being worried that maybe there are effects that we should account for just in terms of the behavior of those that only decide to take 3 doses versus 2 doses. And therefore, we took only those that took 3 doses. And as you can see here, we compared between those that were 12 days onward versus now the control group would be people that decided to take the 3rd dose, but we're looking at what happened to them 4 to 6 days following the booster dose. And we think that even under this analysis, we think that we're getting about 5-fold reduction, meaning significant protection also in this more stringent or conservative type of analysis. Let me move on to show you what we get for the severe results. Here you're seeing what happens for the ages 60 and above in terms of severe COVID-19 for the same study period. And we're seeing, again, a very significant decrease in the rate on the order of 10-fold or higher, and an absolute rate difference of 7.5 severe cases per 100,000 person days. Going back to the issue of Delta versus Alpha and waning, I want to point out that overall what we're seeing, if we had in terms of confirmed infection, if after waning we're seeing something on the order of 50% versus the Delta, which is what is also observed in different studies from around the world, with a 10-fold increase, which is roughly what we're seeing, you get back to about 95%. Similarly, if you start from about 80% vaccine efficacy against severe disease, with a 10-fold increase, you get to about 97% or higher. And these are similar to the reports of what happens in terms of protection against the Alpha variant with the fresh vaccine. So overall, it seems like with the booster dose, we are getting again the protection that we originally got against the Alpha variant. And I want to point out that it's very hard to decompose what is the net effect that only comes from the waning or only comes from the difference between the Alpha and the Delta. What I've shown you enables us to do some of that, but overall I would say, even if you can't decompose exactly the effect, what we're seeing here is that in totality, the combination of both gives you the results that I just presented. I want to finish by just seeing what happens at the national level. This is what was the reproduction number R that we observed in Israel. And as you can see, throughout the month of June, and even before that, we were at about 1.3 to 1.4, which translates to a doubling every 10 days, which relates to what Sharon was saying about the fact that we had over 100-fold increase in the prevalence. This is what happened following in the following weeks and months. We tried to reinstate the green passport, but that did not have a marked effect on the production number. And then with the booster campaign, with a delay that is roughly in line with what we expect, we started to see a continuous decrease in the reproduction number. You can see that this took a while, and therefore we had to make a decision also for the other age groups where we still had an increase in the numbers and the R was still above 1. This shows you, again, the effect at the national level. What you're seeing here as a function of time is what would happen to the number of new daily cases in terms of confirmation following the administration of the booster dose. This was for the ages 60 and above. And we're seeing that with a delay of about 2 weeks, we're seeing a decrease, whereas for the other ages where the booster dose was still not administered, we're seeing a continuous rise. This is in terms of confirmation. Here you can see the picture in terms of what happened in terms of severe disease. So we're talking about daily severe cases. you can see the booster dose being administered, and you're seeing that with a delay, you start to see a sharp decrease for those vaccinated versus those that were unvaccinated, in which the rise continued and did not go down significantly. Okay, Sharon? Sharon, you're on mute.
Thank you. You can see here the projection that we were looking at. The pink projection was based on no booster at all. And looking at the reproduction number, as Ron said, we were doubling every 10 days, and we got to places of thousands of cases, doubling every 10 days. It's scary. And the fact that we had roughly 1.5% of those confirmed cases turning into severe and critically ill patients. So you see here the pink line, which is the model we were looking at, that was based on the reproductive number, the cases, number of cases, confirmed cases that we had each day, and then how many of them would turn into being severe cases, and then accumulating them over time. And you see the purple one looking at a model taking into consideration a booster dose with 80% compliance rate. And the black line is actually the line of our data. So if we only looked at the model at the end of August, if we had not started booster doses at the end of July, we would have come to the capacity of Israel hospitalization capabilities and probably have gone beyond it. So 2,000 active severe cases that are hospitalized in hospitals in Israel is way beyond what we experienced in the third wave. Just to give it context, we were at 1,200 cases, and it was stretching. We had increasing mortality rate. It was a stretch. So this, we were anticipating at the end of August, 2,000 cases, active severe cases a day in the hospitalized. So what happened is with the booster dose, we were able to dampen that effect, and our severe cases now that are hospitalized are roughly 700 or less, and that has stayed stable, even though we still have days of 10,000 confirmed cases a day. So the other point, except for effectiveness and what we think is important to see with the vaccine, the other really important point is the safety. So I'm going to show you a few slides of the rate of events that are reported to the Israeli Ministry of Health. I want to emphasize from the get-go that we are sure to have underreporting, probably the same at every dose, but even if we have more underreporting at the third dose, we still would think that serious adverse events would be reported to us. And I will touch on myocarditis in a moment. But this is generally the adverse events reporting to us from the first dose, the second dose, and now the third dose. And what we can clearly see is that for systemic adverse events, we didn't see any new types of adverse events, and the rate, to be modest, is at least the same, if not lower. And if we look at local adverse events, we would still see sort of the same trend. We don't see any new adverse event. We know that there's more lymphadenopathy, but we're not seeing any new adverse events, and the rate is smaller. Again, I say that with caution that it's probably underreporting. When our HMOs are doing direct calling people or sending them questionnaires, they get more than that. But I want to emphasize on the serious adverse event, because this is what is really important to us. And we had 19 serious reports following the third dose for more than 2.8 million booster doses administered, and each one of them is being investigated by an independent clinical work group using all the data from the hospitals, from the HMOs, to try to figure out if this is connected to the third dose or not. So what we have been getting is 7 reports on a serious adverse event following the third dose of the ages 12 to 64. You see how many vaccines it was, over 2 million. And we had 2 allergic reactions that are noted as connected to the third dose. We had a case of myocarditis in a male in his 30s who was hospitalized for 2 days and discharged. And we had a case of Guillain-Barré and Bell's palsy that is possibly connected to the dose. And then 3 cases of DVT, PE, TIA, CVA, and VT in a runner that happened during a routine stress test. All 3 of them was not deemed connected to the vaccine by the work group. And among 65 and above, you see over 800,000 vaccinees. We had 12 cases of serious adverse events. The first was suspected encephalitis, a guy who came in with fever and confusion. And for him, it was the second time it happened. It happened to him after the first dose. Did not happen after the second dose, but did happen again after the third. And that's a possible connection. A vitreous hemorrhage that is possibly connected. A CVA that is still under investigation. A bulk of cases, 4 or 5 cases that are infection origin, septic shock, thrombocytopenia due to sepsis, 3 cases of UTI and pneumonia that was deemed unconnected to the vaccine, and then 3 cases of mortality that was not connected, people with very multiple comorbidities that had reason for their demise that was not connected to the vaccine. And so the myocarditis focus, I wanna emphasize first on this sentence. Most young vaccinees received booster only in the last 2 weeks, so we don't have a full follow-up for them for 30 days as we want. We continue to follow them. Another important point is in Israel, because of the myocarditis, that was a signal. We saw it in the second dose of the vaccine. We saw increase in cases among young, mainly male, between the ages of 16 to 30. So you see here increasing cases after the second dose, and that was usually after the 4th or 5th day or during the 4th or 5th day after the second dose. So to some extent, we believe that some cases should have popped up in the 2 weeks follow-up that we have so far for several of the vaccinees. But still, we need to be very cautious. We had only 1 case, as I said, of the 30-something-year-old male. In the myocarditis cases, we're actually doing active surveillance. So it's not just reporting to us. We are contacting each hospital every week to get all myocarditis cases, not just following vaccination. And so we feel here much more safe that it's not just under-reporting effect. And our last slide is really the summary. So the booster dose in Israel was effective and so far had safety profile similar to the other doses. We saw that the booster dose improves the protection by 10-fold against confirmed infection, and at least for elderly against severe COVID-19. What we saw is basically that the post-booster efficacy against Delta was similar to the pre-waning efficacy against Alpha. It's like a fresh vaccine. And the adverse events were not more acute than the first or second, and we didn't see any new severe cases of adverse events. Based on the data that we continuously collect, we are presenting this to our Vaccine Safety and Effectiveness Committee, and they have approved by steps giving the booster dose after 5 months to people starting from 60 and then 50 and then 40. And so we are rolling now in the vaccination campaign, and administration of the booster dose helped Israel dampen severe cases in the 4th wave. Thank you for your attention.
And thank you both so much for these valuable data. I was about to ask a two-fold question, which I usually don't like to allow, but first about myocarditis, but you presented very carefully information, including the fact that younger individuals really have not been heavily vaccinated as yet. So the age is there, the age cutoff is hard to determine. One point of information, the second dose in Israel with the Pfizer-BioNTech vaccine was typically given after 3 weeks or delayed?
Yes. Yes. So we started the vaccine campaign after the FDA approval, exactly by the protocol approved by the FDA with 3 weeks apart.
Okay, thank you. Dr. Pergin.
Thank you very much. That was a really thoughtful set of slides, and we really appreciate you sharing with the committee. I had a question specifically. It seems like you have an opportunity to look at demographic differences between individuals who were eligible to get vaccinated with the booster but didn't. The group that only received 2 doses versus received the 3. Do you find any demographic differences? You have a really robust medical record, and I'd be really curious to know, are there differences that might suggest maybe that the group that received the booster were either higher risk or did differential levels of protection in that?
Yes, so I would say we definitely looked into this, and there are differences which we account for in both in the Poisson regression as confounders and in the matching approach also as confounders. We see them, for example, in terms of the tendency to take the third dose, which is different among different demographic groups in Israeli society, among different age groups, and this is all reported in the paper that was published. You can see in the tables there are really significant differences, but all of those are supposed to be accounted for inherently in the way we're doing the analysis.
Dr. Kurilla.
Thank you, Ardo. See if my camera is actually working this time. Nope. Okay. There we go. Yes, it is now.
We see you
yes, thank you for the presentation. Very, very, very insightful. One of the things that stands out for me from your data is that the waning of immunity, which seems to be more waning of immunity rather than a Delta-specific phenomenon, although there may be a small component, it would seem that one would have to conclude either that the mRNA vaccine in general, that platform, or else the shortened dosing interval does not really, between the 2 doses, does not lead to long-term good durability of the immune response. And those individuals at risk, particularly for severe disease, don't have a good cell-mediated immune response and are relying entirely on their neutralizing titer and other serology, which is dropping off rather quickly. Your boost clearly does that. So my question to you is actually twofold. One, although it's very early, do you have any evidence that the 6-month boost is actually contributing with a better dosing interval to give you more long-term durability in the immune response? And is there any change in the kinetics of the antibody response, or do you anticipate that just every 6 months you're going to have to keep boosting these people?
So I'll start with the end of your question. I think this is very early. We can't really tell. We know from other viruses that sometimes, like in hepatitis, you get a dose, and after a month a dose, and after 6 months a booster, and you have protection for many, many years. Whereas for influenza, we need to be vaccinated every year, and I think it's not really clear where this is going. We definitely don't have any plans at the moment to boost every 6 months. We'll base it exactly as we did here based on the results. We'll continue to monitor and see if there is, again, any waning effect, but it may be that we won't see that after the booster we'll have a higher protection for a longer period of time.
I would add that I think that the effect of the Delta versus Alpha is not very small. I think they're both very significant, both the Alpha versus Delta and the waning. And there's also maybe an interaction, a synergistic effect from both of them together. So I wouldn't think about it as a small effect.
Thank you.
Dr. Levy. And quick questions and quick answers, please. We're going to have time to come back again later.
Hello. I'd like to thank the presenters for a wonderful presentation and impressive progress. One question I had was related to the decision to give boosters to the younger individuals as well. As we know, there is some increased risk of myocarditis, particularly in younger males, and it seemed like there was relatively less data in the younger age group. So what were the considerations from a policy perspective of recommending a booster for that youngest group? If Dr. Elroy-Priest can say a few words, I'd really appreciate it. Thank you.
Sure. So first of all, we know from research done by Clalit HMO in Israel that the risk of myocarditis from corona itself is higher than the risk from the vaccine. And when you have really roaring pandemic with a surge of thousands of cases and doubling every 10 days, the risk of people, even young people, to be infected with corona and get the myocarditis is higher than being vaccinated. And that risk, and I have to say that there is a work being published or in the review process from Israel about myocarditis, and in 95% of the cases, the myocarditis was not severe. And so we feel that when we weigh a pandemic roaring with, we saw reproductive number of over 1.3, doubling every 10 days, the risk even for the young adults would be higher. And I have to say something about a mix of our population. So if we only vaccinated the 60 and above, this is roughly 16% of our population. Most of our population is younger. And when we looked at the cases, confirmed cases that we had in the fourth wave, 15% of them were 60 and above. So the majority was not the 60 and above, and we believe we wouldn't be able to control the pandemic just by vaccinating those 60 and above. When you have roaring pandemic and we know that the numbers are doubling, then we really have to make sure that we get to a reproductive number of under 1 in order to control this. And we wouldn't have been able to do this, we think, just by vaccinating the 60 and above.
And any sense of
we're going to have to move on.
Okay.
We've got a list of about 8 people who want to ask questions. Dr. Gans. Go ahead, please. Dr. Gans. We're going to have to go on to Dr. Rubin until
Sorry.
Dr. Gans.
Sorry.
Okay, okay, Dr. Gans, quickly.
Thank you. This is wonderful and very provocative given that you were ahead of us and so foreseeing the future. So thank you for sharing your data. I had a question because not only, and as you suggested in your last answer, in order to really control a pandemic, we actually have to control secondary cases, so the ability to spread. And what we are starting to see is in our vaccinated households, we are starting to see spread into our younger populations who are no longer seemingly protected by, herd immunity around them. Were you able to look at the secondary cases within households? You have the opportunity to do that. People are getting tested. So what is the lack of protection for children when you started seeing those surges, and then was there any control of that protection to those in our societies who haven't been able to be vaccinated?
Quick answer to a complicated question, please.
We'll do our best. Our fourth wave actually started with younger people coming from abroad, and their kids. The older adults were vaccinated. The kids obviously were not, and we saw a surge in cases among both, and that was the beginning of our fourth wave in kind of two spots, and then spread in a community way. What we saw at the beginning of June is that the ability of a vaccinated individual to spread it to others was lower than the non-vaccinated. So roughly 80% of the people who were vaccinated at the beginning, did not infect others outside their household. In their household, it was highly contagious. So vaccinees that became confirmed cases were infecting their household, and that actually led us to a policy that said if you have a confirmed case at your household and you need to take care of him, a child, you can't really go in and out taking care of him because you'll be infected and you'll infect others going to work. So we definitely see that cases that are vaccinated, doubly vaccinated, that are no longer fresh, what we call more than 6 months from the second dose, are infecting other people. It's obviously less than non-vaccinated, but we're seeing that, especially in their household.
Dr. Rubin, the final question before we are forced to take a break.
Thanks, Arnold. Thank you very much for the presentation and for generously sharing the data. The Israeli data are very important for all of us making these decisions. So it's been a great laboratory, and you've done a very nice job of it. Dr. Gans just mentioned how one of the goals would be to prevent transmission and reduce the size of the epidemic. But of course, another goal is preventing severe disease. If you look at it through that lens, can you identify the people who are likely to get severe disease? Do they look like the people at high risk otherwise? In other words, could you focus the administration of a third dose of vaccine on particular groups to give a very high yield for preventing severe disease?
So the obvious question is those who are 60 and above and those who have comorbid conditions, especially morbid obesity. We see that as a very clear chronic disease that is a risk factor for COVID-19. However, as I said before, having about 60% of the population over 60, it's really we can't imagine just vaccinating that group, knowing that 85% of the confirmed infections are among the rest of the population, and trying to get to a reproductive number of under 1 so this pandemic starts to shrink, this wave will start to fall. We have to, in our opinion, in Israel, we had to vaccinate more than just 16% of the population to get there. So we definitely see mortality among young people who are not vaccinated, 30, 25, 41, really young people. And we started to see the same trend of severe critically ill patients among those who are 40 to 60 and have been doubly vaccinated. And we just didn't want to wait to see those results, and we knew that we needed to vaccinate a larger proportion of the population in order to get the numbers down quickly. And I have to add one more thing. We always look at the severe and critical disease status or mortality. I think there is also importance in long COVID among those who are infected. And so we can't really put this aside and say, this is influenza. If you went through this, it's fine. We see that there is a high percentage of people, including young people, who are left with symptoms for over months. So there are several reasons why we wanted to make sure that we overcome this fourth wave.
Okay, thank you so much. Very good and very informative presentations and a very vigorous discussion, which actually will be continued in the question and answer session, which comes later. And I hope our speakers from Israel, especially where there's a 7-hour time difference, will be able to stay with us, and from the UK as well, for that discussion later on. So 5 minutes for a break, and then we resume again.
Thank you.